So while our audience members are gathering their questions, I will start with one around the area of messaging. I think we heard from all of our panelists that messaging is a challenge in all of these emergencies. Working with the media is also a challenge. And we even heard from Dr. Baums in his presentation a specific case study where there were conflicting messages between two different governmental entities in one of these fire responses. So Stella, I'll start with you, but I'll invite all of our panelists to weigh in. What types of strategies can be implemented to ensure not only effective messaging, but to try and minimize discrepancies or conflicting messages being sent out by multiple stakeholders?
Absolutely. And so you can imagine we're huge, we're the size of some countries, and we try to communicate as quickly as possible with our state. And we pay close attention to what the state messaging is putting out, and look at what we're putting out. I think that policy group that I highlighted for you all, that includes our subject matter experts and includes our leadership, we put a lot of resources toward, we have a chief science officer, we put a lot of resources toward thinking through all of the interventions that we are recommending, and really making sure that it's as consistent as possible with all the things that we're seeing are being put out by partner agencies. If there is a difference, but we still feel strongly that there should be a difference, we try to give a heads up and we try to manage that accordingly. There will be times when we feel in our jurisdiction that what our guidance is going to be is different from what others are saying. So if we are making that choice, we'll try to be as upfront with our partners as possible to say, hey, we're going to go out on this in this area in a different way. But you know, that's best case scenario. I think the way to equip yourselves is to put a lot of resources into watching what is getting put out by your fellow experts in that same field, and then doing your best to coordinate and connect as possible. Also, as I mentioned, trying to be the first to step out and equip yourselves quickly. What we recently did with the measles response, as soon as we started to get, see that we were going into outbreak mode, we thought about our clusters, groups of stakeholders that we would want to, who would sort of be on the front lines of either most at risk for being exposed or be the first to see a case. So we worked with our healthcare provider community. We worked with our airports because of the international travel risk. And we quickly set up telebriefings straight with our director and our health officer to give them the messages as soon as we possibly could. So just like I said, front loading, a lot of communication. It's a lot of times we want to just make it perfect, and it takes a long time to get out the door because we want it to be perfect. We have to be ready to move quickly and say, you know, it's perfect enough at this point in time, and we got to engage people as quickly as possible.
Thank you. Are there any questions in the room? David.
Hi, Stella. It's David Eisenman.
Hi.
Hi. I'm not going to pin you down for coffee now. I'll do that on email. I have a question for you, though, and maybe this is an opportunity for you to also tell the audience about your use of the Empower database, what that is. So maybe I'd love to hear how you used Empower to save people who are medically dependent and get that information to the first responders. And then more importantly, in your use of it, what challenges did you face and what kinds of experiences did you face that you might want to pass on to federal agencies to improve its use in the future?
Thank you. So the Empower data is Medicare beneficiaries who have durable medical equipment in their homes. So that's one way. It's an indicator for the folks who would be most vulnerable for an evacuation, or if an area if power is cut off to an area. We have that information. We have the staffing to be able to get through the administrative processes to receive and then clean that data and have it sort of as lists that if we know that a mass area is going to be affected, that we can work with our response agencies to let them know these folks will be most vulnerable if they're in an area of evacuation. So that's how we use it. It's taken, you know, some resources to be able to get through the processes, to be able to have that handy. We've had the benefit of a large health department with a lot of resources to do that. It doesn't have phone numbers. So you have names and addresses, and you have the type of equipment that they have at home, which would give you a sense. I mean, and it's equipment that ranges from a bed, like a movable hospital bed, to a ventilator. So, you know, you can see that's a broad range of things and would be indicated for a broad range of different vulnerabilities that people can have, whether they can move, whether power outage or poor air quality would be a special problem for them. So the way that we use it is we show up to the EOC, have our list handy, and we hear of new areas that have to be evacuated, power outage to certain areas. We work with those responders, and we have to make sure that we, in a secure way, can provide that information, and then we have to be very careful about, you know, handling it properly and destroying that information right afterwards. Sometimes we have to use hard copies. It kind of depends on the response. We've done this. We've been able to use Empower data to inform evacuations for a handful of different responses, both wildfires and for public safety power shutoffs, which is a new thing that some of the utilities companies are doing preemptively when they see a risk for a fire hazard. But I would say to our federal partners, and we actually just had a conversation yesterday afternoon with some friends at ASPR about this, that the easier that we can make it for health departments that don't have the benefit of the resources that we have in LA County, where it's like one person who's trying to get this done, where they're pulled in a million different directions at the same time, the more that we can work together to augment or support. We're happy to support other counties. If we can receive the data and clean it and get it back to them, or if, you know, we can have some sort of regional work group or support, that would be helpful as well.
Hi, I appreciate all of those presentations. My name is Reginald Tucker-Seeley, and I'm a member of the Roundtable on the Promotion for Health Equity. My question is specifically for Dr. Schreiber. I appreciated your approach to focusing on pre-existing trauma and disparities. And so the framework you presented was mostly relevant for children. Do we have anything on the other end of the life course that focuses specifically on the challenges of older adults, especially given that they're going to probably likely managing multiple chronic conditions, trying to navigate disasters and the wildfire situation?
I'm not sure I totally understood I got the context. I'm not sure I understood the question. I'm sorry.
Yeah, so many of the examples or the example that you showed was relevant for children, sort of assessing mental health conditions in children. Is there a similar framework for older adults, or does that same model work with older adults as well?
Our triage model started with adults, and we extrapolated. It started with kids, and we extrapolated to adults. Usually, things go from adults to kids.
Yes.
So yeah, we think the same things. And it's not a direct interview. So in other words, our tool is designed to be, quote, quiet questions, observable, so don't require extensive interviewer training, don't require revealing potentially stigmatizing information about, you know, internalized mental health conditions. So yeah, we've tried to come up with a strategy that cuts across both ends. We now have interest with some of our end users that have our tool basically for large-scale events, for example, LA County. The good news is LA County's not really had a triggering event to activate our system since it's been in use. They use it yearly around exercises, the statewide disaster medical exercise, but apart from that, they've not had a triggering event. So what happens is when you have a mass casualty strategy and resource, and it's not used, potentially, you know, it ends up on the shelf gathering dust. So we've had some interest from some of the broad spectrum in users like LA Unified Schools. We have a project also in North Central Texas in Fort Worth schools. Hey, can we use this to look at helping us with trauma-informed care decisions on a regular basis? We have a group in LA County, for example, that's interested in using our mapping capability to create a trauma temperature within the health divisions within LA County, the regional divisions, and to look, are there hot spots, so to speak, where the trauma temperature is higher than in other areas, to then inform follow-on strategies. Hopefully that's responsive.
Thank you. And we are a little bit over on our time, so we're going to give the final question to Dr. Jonas.
This question is actually for everybody, but Dr. Schreiber perhaps more specifically. Is there a risk at intervening inappropriately too early? In the military, they found that some of the very early frontline mental health interventions actually exacerbated problems because, as you showed in your data, the vast majority of people are going to come back, they're resilient, they're going to be fine. And so identifying those folks is not necessarily that easy at the beginning, even if they have some of the risk factors that you've talked about. And I'm just wondering if there's an issue about that, or if you've experienced or had any data on that information.
So I think that goes to the one-size-fits-all. And I think what's tended to happen is mental health people deploy, including in military, and some of those combat operational support units that exist, and they offer kind of a one-size-fits-all approach based on distress. There's been a heavy use of something called critical incident stress debriefing, CISM. It has a lot of appeal in the first responder community. However, there's also been some evidence that not only not beneficial, but it worsens some folks, particularly those that are very highly exposed, and they've not included any kind of systematic assessment process in that. So I think, so based on that, NIH had a consensus after 9/11. It was DOJ, Red Cross, VA, HHS, CDC, and basically they recommended against routine use of that approach. WHO followed after that. So a lot of the problems that have come from acute interventions have been tied to one specific application of one of those interventions, CISM. Then psych first aid came along. And I have a great interest in that. As Stella mentioned, we've worked with LA County Public Health to create a neighbor-to-neighbor version of that. And it is designed to avoid some of those pitfalls. One of the things about debriefing that was found to be problematic was it basically required recital of your worst moment. And essentially that was re-traumatizing, and without any skills to give the individual to manage that activation. So I think it's not that all acute interventions are problematic, it's the ones that have been most routinely applied. And you know, I see now that a lot of entities are relying on psych first aid as kind of the replacement. Well, psych first aid is not a disaster response plan, in my view. It's a component. Maybe its primary component is to help triage who needs follow-on services. When you target interventions to match needs, they're generally quite well accepted. That's my experience.
Thank you very much to all of our panelists. I do know that there are, thank you, yes. There are others of you in the audience that had questions, and we apologize that we ran over on our time, but hopefully you will be able to connect with our panelists and get your questions answered over the lunch break. So with that, we are adjourned to return at 1:30. Thank you so much.